Thank you very much for attending our presentation. I'd like to speak about PRESPECT, a method to personalize myocardial perfusion SPECT to improve performance on defect detection. We begin with the motivations for this work. Myocardial perfusion SPECT is a very common imaging procedure to evaluate infarction, ischemia, and diagnose coronary artery disease. Specifically, one is looking for areas of lower uptake within the myocardium as represented by this yellow arrow. Current acquisition protocols for myocardial perfusion SPECT are mostly identical, especially when it comes to the time per projection view. For example, if a patient is imaged in the clinic with 60 projection angles, the amount of time spent in each angle is identical and is roughly 20 or 30 seconds. Hence, we could say that a uniform time protocol is in place. In this context, however, it is known that certain patient anatomies, such as those with large breast volume or large body habitus, experience significant attenuation artifacts, as can be seen by this example of a female patient with a false anterior defect, with a breast shadow seen on projection data. The current solution in the clinic is to increase the radiotracer dose administered for such patients. However, since protocols have been generally developed as a one-size-fits-all, with the exception of this increased radiotracer dose, what if we could try and personalize the process of imaging for these patients to improve image quality without resorting to increased radiation exposure? In this setting, we recognize that the CT map often acquired for attenuation correction contains patient-specific anatomical information such as the location and boundaries of major organs. Additionally, we also know that for the detection task at hand, the Bayesian ideal observer, or the IO, is an optimal observer that has been used to maximize performance of an imaging system or protocol in the past. It has also been shown that through the IO, different projection views contain different amounts of task information when it comes to myocardial perfusion SPECT. Therefore, we could set out a goal to optimize acquisition protocols for myocardial perfusion SPECT in a manner that is personalized to each patient, but is guided by the ideal observer as well. To this end, we propose a method which we dub precision SPECT or PRESPECT, and we will now move into the mechanisms of our method. The schematic is as follows. We start with a defined patient or phantom anatomy on CT, and then use that to create a population of varying object realizations which are consistent with the anatomical boundaries of the CT. From here, we can simulate the process of SPECT imaging and obtain projection data. Then, from these projections, we can calculate the IO detectability using equations given by Drs. Shen, Clarkson, and Barrett, and then use that to perform a constrained optimization to obtain an anatomy personalized protocol. This protocol is once again specific to the defined patient anatomy that we began with. The optimization for this protocol is as follows. For all n views, we will seek to maximize the total detectability, which is defined as the sum, across all n views, of the product of acquisition time and the patient-specific ideal observer detectability. The constraints at hand are necessary in order to ensure proper reconstruction, because otherwise we may simply try and maximize detectability by spending all of our projection time at the one most informative angle. Because we would like to have our images read in reconstructed form, we thus impose two constraints. One is that there is a total scan time over all n views of t, which is equivalent to that of a uniform or conventional protocol, in order to not give an unfair advantage. Additionally, we give a minimum and maximum acquisition time per view in order to ensure that no view gets too little or too much of the acquisition time. We now provide some intuition for what the PRESPECT protocol looks like for a given patient. If we have a PRESPECT protocol and a uniform or conventional protocol, where the PRESPECT protocol is represented as a ratio of the amount of time that our method would prescribe divided by the amount of time spent by a uniform method, then for a given patient, we can observe with this animation that PRESPECT spends a heterogeneous amount of time across the projection views, focusing time on specific views, whereas the uniform protocol distributes this time evenly. Next, we'll move on to the evaluation of our method, beginning with an in silico imaging trial. This is a potential means to evaluate clinical imaging technologies, and in our case, we use distributions for body dimensions, left ventricle dimensions, the breast volume in order to choose patients with large breast volume, left ventricle angular orientations, and the sestimate tracer uptake values for major organs. This allowed us to model a realistic population of patients for our imaging trial. Next, we will be looking at the schematic of our in silico imaging trial, beginning with a preliminary sizing study, which we conducted with 50 virtual patients and an effect size of 0.025. We thus determined that we needed a total data set of 396 patients, and thus we simulated 400 virtual patients using the extended cardiac and torso, or XCAT phantoms, with large breasts, of which 200 were healthy and 200 had defects of varying types present. From here, we calculated the PRESPECT protocol for all patients, and then imaged them virtually using a Monte Carlo simulation method known as SIMIN for both PRESPECT and conventional uniform SPECT. The specific scanner used was a GE Discovery 670 with low energy, high resolution collimators. From here, we then reconstructed all images using ordered subsets expectation maximization, and then post-processed and reoriented to short axis. Finally, this allowed us to evaluate our primary endpoint, which is the defect detection AUC, or area under the receiver operating characteristic curve, for both protocols for all n equals 400 patients. For our in silico imaging trial, the primary objective of it was evaluating the task-specific performance of our PRESPECT method versus that of conventional uniform SPECT for patients with large breasts. The figure of merit used to evaluate this primary objective was that of the area under the receiver operating characteristic curve of the channelized Hotelling observer with anthropomorphic channels on defect-centered images. In other words, we used a numerical observer that has been shown to emulate the performance of human observers on the task of defect detection for myocardial perfusion SPECT. Next, we have the results for our in silico imaging trial, and we can see that the receiver operating characteristic curve of PRESPECT was clearly above that of the uniform protocol. The specific AUCs obtained were 0.75 versus 0.70, with a difference in AUC of 0.05. This was deemed to be statistically significant by DeLong's test, which yielded a p-value less than 0.01. We can thus conclude that in silico imaging trial we conducted shows PRESPECT significantly improved defect detection for patients with large breasts. We can also corroborate these results by looking at some sample reconstructions. Here we see that the PRESPECT protocol improved defect visualization for an anterior, inferior, and lateral defect. And this suggests that we could have an improved visualization of defects by using acquisition with PRESPECT for a variety of defect locations. We also performed a second evaluation, which was a retrospective clinical image analysis. This was a qualitative analysis of our PRESPECT method versus that of uniform protocol by using data acquired retrospectively from patients. Specifically, we used n equals 12 female patients with large breasts and abnormal scans, and this was pharmacologic stress tetraphosphate SPECT CT data from the Mallinckrodt Institute of Radiology. From this dataset, in order to calculate our PRESPECT protocol, we used Total Segmentator, a well-validated segmentation software for CT images, to obtain major organ masks. Because images for these patients were already physically obtained, and thus we could not scan each patient for twice the amount of time at certain projection views, even if it was demanded by the PRESPECT protocol, we opted to use binomial sampling to derive 50% dose PRESPECT and uniform projections from the original projection data. This allowed us to compare a method with the uniform method at the same dose level. To this end, we could also then compare accurate visualization of defects in healthy regions of the myocardium for both protocols by using the radiologist report and the normal dose image as the ground truth standard. Verification of these results were performed by 2 nuclear medicine physicians and 1 cardiologist. Next, we'll look at the results of our retrospective clinical image analysis. Assuming the normal dose and clinical read images as ground truth, we saw that when it came to accurately visualizing the true defects with correct extent, location, and severity, PRESPECT was accurate on 8 of the 12 patients, whereas the uniform protocol was only accurate on 6. When it came to avoiding or not having any false defects on the image, PRESPECT was correct in 10 patients, meaning that there were only 2 patients with false defects, whereas uniform had false defects in 6 of the patients. We can thus conclude that PRESPECT showed better visualization and fewer false defect artifacts, leading to improved specificity at a similar level of sensitivity for these n equals 12 patients. Looking at sample images as well, we can clearly see that for the first column, with the normal dose image on top, there is a spurious false lateral defect present on the 50% dose uniform image, which is avoided by the PRESPECT protocol. The same goes for the second column, where we see a much higher intensity inferolateral defect spanning about 1/4 of the entire wall, which is not present on the normal dose image, the PRESPECT scan, or the radiologist report. And finally, for the third column, we can see a large extent anteroapical defect that is cut short by the uniform protocol, presenting an inaccurate defect extent. We can thus conclude that the sample images also suggest more accurate visualization of the defect and improved specificity with PRESPECT. In conclusion, we have designed an ideal observer-based strategy to derive patient-specific acquisition protocols for personalized imaging, which we dubbed PRESPECT. We have thus evaluated PRESPECT at both low and normal dose, as well as on modeled and clinical data. Some limitations of our work in future studies to be conducted include those with human observers rather than numerical observers. And we could also look at a larger scale evaluation with clinical data, such as that of prospective acquisition at normal dose, or one that included healthy patients as well. And finally, we could also look at other categories of patients, such as those with large body habitus that are male, as represented by this sample CT image. Very much for listening, and thank you to our collaborators and funding support. And I'd like to take any questions at this point.